protection, excellent for streptococcus, and even takes care of MRSA. So you're very comfortable. But you don't read that mupirocin is very highly protein bound. So when you have an oozing lesion, the amount of free drug that is available is negligible. So you're generating resistance. And this child already has an atopic dermatitis and has received few courses of fluticasone and mupirocin, what is called as Flutibact in the past, because we know staph brings about a flare-up. So the problem here is I could be dealing with the mupirocin resistant Staph aureus. There is a lot of oozing, and this protein might bring down the levels of mupirocin at that thing. So I would definitely go in for ozenoxacin because it's not affected, less protein binding, and the time to kill is just 48 hours. Very efficacious and also takes care of mupirocin resistant MRSA. Fine, and the effect on the flora is negligible.
So what about fusidic acid?
I didn't put fusidic acid here because the resistant rates for fusidic acid has gone up. I will come to all those drugs when I go into topical preparations.
Can you please tell what is this ointment and cream which should not apply on the face? What is the difference?
Yeah, so that's what I was trying to tell you. An ointment is more oily, greasy. The vehicle that is used is PEG, polyethylene glycol, which is an irritant. So even the mistake that we do, I see a lot of doctors using mupirocin for nasal application. There is a separate nasal application. So it was when we had this Bactroban which first came into the market, we had the one which was made in, it was a separate preparation. It's not with PEG. It's not with mineral oil, and that was being used in the nose because your vehicle should be very favorable for the nasal epithelium.
How many days they should be applied?
Ozenoxacin 5 days. 5 days. So here is a child with a bulla to begin with. Fine, and then it turns out to be this. What you are seeing around. Is there a pointer in this? No. So what you are seeing around is the remnants of the roof that has ruptured. So what is this? What is this? Sorry. So I was talking about this particular thing. This is bullous impetigo. Again, superficial. Epidermis. So there is no need to panic. There is no need, there is no scar formation. You need to understand this. Fine? And it's because of the toxin. The exfoliative toxin that is liberated by Staph aureus. Debilitated, bedridden, lower limbs, buttocks, and you get a crusted lesion like this, and what you do is you remove the crust and you get a saucer shaped lesion with pus in it. What is this? This is an ecthyma. Fine. The problem with an ecthyma is scar formation. This has to be, you have to take systemic antibiotics because this is deep seated. Fine, you can use a local to prevent spread, but you require a systemic antibiotic. So here is a child who enjoyed his trip to Thana and had a lot of fun in the water park, was coming down the slides, going up and coming down the slides. Very crowded during the summer season. No? And the cleanliness is a question mark. Chlorination is either over chlorination or under chlorination. And the very next day, the parents noticed this sort of a rash. So you have these, it's almost like a folliculitis. And when you see, yes, it's a folliculitis which is superficial. What is this? Can you be a bit loud?
Yeah.
No, no, this is not an urticaria.
Follicular urticaria.
No, this is not so.
Insect bite.
So other than staph and strep,
Bite.
can you
Insect bite.
Pseudomonas. Exactly. So this is what is known as spa, water park, hot tub, jacuzzi folliculitis. And this is caused by Pseudomonas. Self-limiting, even if you don't treat, nothing happens. But in a small set of patients, you may have to use something that covers Pseudomonas, either orally or locally. Fine? An obese individual, 16-year-old boy, one thigh rubbing onto the other, comes to your OPD with this sort of a lesion. Minimal itch, and you use a dermascope or you focus light and you see a little bit of scaling, a nice border, a red hue to that skin. And especially when you hear him talking about the newer molecules and we went through that fungal epidemic, you start wondering, is it Candida? Is it Tinea? What is it? So what is it? This is called as erythrasma. So in addition to staph and strepto, you can have Pseudomonas. In addition to staph, strepto and Pseudomonas, you can have Corynebacterium. Again, a part of the flora. Fine, and you can get 3 conditions in this. So you have some kids who come into the OPD with very foul smelling leg when they remove their foot from the footwear. And when you look at the sole, you will find pits. The sole has been eaten up. That is called as pitted keratolysis and a very foul smelling foot. Or you could get trichorhexis, mycosis axilla, which is basically you find these yellow flakes on the hair in the adolescent kids, where the treatment again is just shaving. And this is called as erythrasma, this particular thing, where the treatment luckily is the antifungals work, the azole works. So you think of one thing and you give a miconazole and it works on this. And you also have a single dose clarithromycin for erythrasma. The best way to pick it up is a Woods light, wherein you get that coral red fluorescence. And this is basically because of the porphyrins which are generated by the Corynebacterium. So when you look at the skin and you look at skin infections, what you need to understand is in undergraduate time we used to divide it as follicular, non-follicular. So when you talk of follicular, if the ostia through which the follicles comes out of the skin is red and there is a little bit of pus on the top, it's superficial folliculitis. The complete follicle is infected, it's deep folliculitis. When you have a folliculitis with perifolliculitis, it becomes furuncle, and when many furuncles coalesce, it becomes a carbuncle. Fine, so that's the way it is. And you have an erysipelas a bit lower down, cellulitis going still further lower down. That's why in erysipelas we may have a margin, whereas a cellulitis usually merges with the rest of the skin. And the toxin-mediated ones would be like staphylococcal scalded shock skin syndrome. And you can also have the streptococcus causing a lot of toxin-related problems. And why this is very essential for you to understand is topical works best on epidermal infections. That's why I was showing you impetigo contagiosa, the bullous and the non-bullous one. Today even ecthyma is now being pushed into the more severe form of impetigo, which is more deep-seated. And anything which goes lower down requires systemic antibiotics. But we still use topical for things like superficial and deep furunculosis to restrict the spread. And you require to understand what organisms are causing it, and you also need to understand the resistance of the organisms in the skin. And why is it happening? So the first one is a superficial folliculitis. You have the hair follicle coming out of the center of the pustule. The second one is a proper furuncle, and the third one is a carbuncle. Now, what keeps your skin intact? So, God has made your skin in such a way that you desquam it. You have almost a 10 layer of corneocytes, which are all dead keratinocytes, which have migrated to the top. They are kept very close to each other by tight junctions and lipid and lamellar system out there. And you also have something called as a filaggrin system, which is concerned